everyone joining us. Thanks for doing that. Welcome everyone to today's webinar associated with the 2024 Society of Counseling Psychology Professional Practice CE series and organized by the Division 17 Health Psychology section. I'm so glad to see folks here and coming in still now. We're glad to be here with you all today. My name is Amanda Mitchell. I am the chair of the SCP, let's see if I can get that out today, Health Psychology section. I'll be sure to drop some information into the chat about our section for those who might be curious to learn more. It's free to join, but we are going to dive in quick today because we only have an hour. And before we do that, I just want to share a brief note about CEs. So participants must join the webinar via computer, laptop, and attend the full webinar in order to earn continuing education credit. Attendees will be responsible for confirming that the Society of Counseling Psychology is approved to offer CEs in your state. Dr. Kana, chair of the SCP CE committee, will send you a follow-up email within 3 business weeks of the webinar, and that email will include a link. So you can click on that link to complete an evaluation and request your CE certificate of attendance. Okay, so with that information shared, I want to turn to our speaker today. I'm excited to introduce Dr. Melissa Ertl. Dr. Ertl is a counseling psychologist and an assistant professor of psychology at University of Minnesota, whose work focuses on addressing social, cultural, and structural determinants of health to eliminate health disparities and promote health equity among underserved and marginalized populations. Dr. Ertl earned her PhD in counseling psychology with a certificate in health disparities in public health and is a licensed psychologist in Minnesota and New York. Dr. Ertl was also the 2023 recipient of SCP Health Psychology Section's Early Career Award for Excellence in Counseling Health Psychology. So we're excited about that. And we really appreciate you, Dr. Ertl, for being here and sharing with us today. We're looking forward to learning from and with you. And the chat is available, I'll say that, but we also have questions, Q&A format there. So I will now turn it over to Dr. Ertl.
Great. Thank you so much, Dr. Mitchell, for that gracious introduction. I'm so excited to be with you all today to share about how taking a social determinants lens in our work as psychologists can enhance the effectiveness of our work and address health disparities. Before I get started, I just wanted to give my sincere thanks to the prevention section for giving me the opportunity to share about this work today. So the title of my talk is Addressing Social and Structural Determinants of Health as a Psychologist. And as I move through the presentation, I welcome and encourage comments and questions, and we'll have at least about 15 minutes at the end of the call today for Q&A and discussion. So I want to start just with our learning objectives. So I do have some goals for us today. So this will really be an introductory overview to this area of work. And by the end of the webinar, you're going to be able to describe how social and structural determinants of health influence health disparities and drive inequities across health outcomes in the US, explain 2 examples of how to integrate social and structural determinants of health into your research, clinical practice, training, and advocacy roles as a psychologist, and really describe how education and training can leverage sustainable partnerships with communities to promote community engagement, culturally responsive practices, and address disparities in communities. Before I jump in, I do want to share a little bit about my positionality to this work. So as Dr. Mitchell mentioned, I do have a public health certificate in the study of health disparities that I received from University of Albany, where I obtained my PhD in counseling psychology. But before I had ever entered a graduate classroom on public health, I had a very visceral understanding of what health disparities were. So I grew up in a very rural part of northern Wisconsin that's considered a medical desert because of the lack of healthcare resources in my home community. And so if someone had a broken arm or they had to deliver a baby, they'd have to travel over an hour in any direction to get to the nearest hospital that could cast a broken bone or complete a delivery. So over 65 miles away. And I grew up in a working class family in a very working class community where people really thought twice before going to the doctor for regular care, or if they needed an ambulance, calling one, just because of the cost the worry about the cost of what that would be. So from a young age, I witnessed how these social and structural determinants influence people's access to affordable and high quality care in communities with less access and fewer resources. And that theme of limited access to affordable, high quality care really continued to be salient for me throughout my education, including during my college years when I studied at University of Wisconsin-Madison and began to be involved in the field of immigrant health, working in communities and outside of Madison, Wisconsin. And it was very clear that any of these community-based efforts to promote familial well-being were very inextricably linked to families' experiences as immigrants living in the United States and the serious challenges that this poses for their access and receipt of affordable, high quality, both culturally tailored and linguistically appropriate healthcare services. And obviously the lack of which can really drive health disparities in these communities. So I want to, as we move forward in the talk, focus on our first objective initially. So really describing and defining how social and structural determinants of health influence health disparities and drive inequities. So what are health disparities? So health disparities are a persistent feature of US society. These are differences in health and well-being between and within groups of people that are socially constructed, unjust, and avoidable. So these are structured patterns of individual ill health and population level morbidity and mortality rates. And in terms of who's impacted, chronic health conditions disproportionately impact individuals from minoritized and marginalized backgrounds. And these disparities are really driven by structural inequities that are rooted in this sort of unequal distribution of power, privilege, and resources in our social conditions. And those affect the way we grow, we live, we work, and we age. And these sort of socially determined, disparities are affected by these intersecting systemic influences. Really, we're talking about social, economic, and environmental conditions. And the number of Americans who are expected to be vulnerable to experiencing health disparities is only expected to increase over the next 50 years. So what affects or determines health disparities? So I've mentioned that they're socially constructed, that they're avoidable, they're unjust. So really, what are these factors that underpin them? So a thoughtful and now, getting to be almost outdated review used really strong community health level data. This was a 2010 review that looked at a great deal of community health data and actually used multiple ways to sort of come up with an estimation of what categories the primary determinants of health come from. And through this review of county level health data, they found that beyond genetics, a population's health is really shaped about 10% by the physical environment, 20% by healthcare access and quality, a large 40% chunk of social, psychological, and economic factors, and about 30% of healthy behaviors or individuals' decisions and health behaviors. And I want to underscore that those behaviors themselves are largely determined by social, economic, and physical environmental factors. And I want to underscore that this chart gives us, really broad stroke, round number estimates based on available evidence. And this research can be really complex to investigate, all of these different facets across populations. But from this chart, you can see that the social, psychological, and economic domains are not only the single largest predictors of health outcomes, but they really strongly influence individuals' healthy behaviors, which are the second largest contributors. And generally speaking, the lower that the social and economic position of a community is, the more challenging it is to practice and sustain healthy behaviors and access affordable, high-quality care. So what I'm telling you right now is that health inequities, they're multifaceted and they're interrelated, but they're not just explainable by health behaviors and just simply access to medical care. So instead, health disparities are really characterized by factors like employment patterns and conditions, poverty and low income and socioeconomic disadvantage, hardship and chronic stress, social exclusion, individuals' access to education and their achievement of it, environmental hazards, colonialism, racism, sexism, homophobia and heterosexism, transphobia, and these historical kind of forces of oppression that have shaped our society, violence and traumatic experiences, stigma, food and housing insecurities, and access to resources and social services. And this is not an exhaustive list, but I really wanted to paint a picture of these kind of factors that, are numerous, that really are contributing to health over and above these other areas that are often investigated and focused on. And I just want to add too that in my work in the New York City HIV planning group, when I was a postdoctoral fellow living in New York City, I got involved in the HIV planning group of New York. And I think this was really illustrated for me through our HIV prevention activities that we were organizing in New York City across the 5 boroughs, and sort of the notion that one of the biggest determinants of HIV status in New York City was actually whether someone had stable housing or not. So it was almost 20% of the unhoused population in New York City is HIV positive. And, this is a massive driver, but it's not, an everyday way of thinking that HIV prevention should focus on housing, but that is critical. So it was a big kind of illuminating point for me to see how all these areas are connected and how our efforts, if we're only focusing on access and health behaviors, we're going to be missing the bigger picture. So I've talked about health disparities, and I've mentioned them as this sort of like heterogeneous construct, and I really want to break it down a bit further. So health disparities are conceived of as this sort of complex, multifactorial construct that includes, of course, what I tend to think about sort of differential access to medical care and maybe specific treatment modalities, but it goes far beyond that to include, disparate care and health outcomes, another common focus, but also factors like stage at diagnosis, incidence rates and prevalence rates, how long someone survives after a diagnosis, their quality of life with a condition, how long they're retained in care, what the burden of their financial condition is, and then, of course, in mortality rates as well. So there are a number of different outcomes that folks can focus on when they actually are studying health disparities, and we find disparities at every level of this continuum of care. And so the National Institute on Minority Health and Health Disparities has defined what populations are affected by health disparities for their purposes of sort of investigating and targeting these factors. And they've developed these criteria really to advance this science and engage in work, promote and fund work that works toward a United States where populations have this equal opportunity to live long, healthy, and productive lives. And they define these groups as racial and ethnic minority groups, including American Indian or Alaska Natives, Asian or Asian Americans, Black or African Americans, Hispanic or Latinx Americans, and Native Hawaiian or Pacific Islanders, people with lower socioeconomic status, underserved rural communities, sexual and gender minority groups, and people with disabilities. So again, this is not an exhaustive list, but for the purposes of the NIH, this is often how health disparity populations are defined. So backing up a step, I do want to really share a little bit about the history of the study of health disparities and how we got to where we are today. So in 1985, the Secretary of the Department of Health and Human Services established the first task force on Black and minority health, and they released a report that documented health disparities. And this is one of the first sort of original documents that defined this as a problem worth studying in the United States and worth addressing. I also wanted to highlight that it was not until 1994 that it actually became a requirement of the NIH to include women and members of racial and ethnic minority groups in clinical research studies. And that was based on the NIH Revitalization Act that passed in 1993. But, up until that point, clinical trials were predominantly male and predominantly white. And when I say predominantly, I mean, numbers often near 100%. So really concerning that up until the mid-90s, health research just did not focus on communities who were most affected by these disparities, which we were already learning and beginning to know. So in 2000, the NIH actually established the National Center on Minority Health and Health Disparities, and that center eventually became its own institute, redesignated as NIMHD in 2010. So that was really the first time that the NIH started to really concretely take steps toward addressing health disparities. In 2003, the Institute of Medicine published a landmark book, which was titled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And, this was like a really watershed moment in the, sort of study of health disparities where the committee really found that even among individuals with access to care, so we're talking folks who are able to access care, significant racial and ethnic disparities existed and were tied really intrinsically to this history and contemporary social and economic inequality, discrimination, and the fragmentation of the US healthcare system. And so this was kind of the first moment where the media really became aware and started to publicize these sort of disparities that were coming to light. In 2004, there were 2 special issues in really prominent journals of the Society for Public Health Education. And in our own field in 2007, the Counseling Psychologist published a special issue on health disparities. And I cite a lot of work in this presentation because it was a big moment for our field where we started to understand how psychologists could have a role in addressing these issues in our communities as well. In 2008, the World Health Organization released a report on closing the gap in a generation, health equity through action on the social determinants of health. And the last point that I want to highlight, which, over a decade ago already, was in 2009, the APA actually started to commit to targeting mental and physical health disparities in the strategic plan and established its own health disparities office in the Public Interest Directorate. So I say all this to note that health disparities have been affecting folks in the United States for decades, and it's only in the last, 10, 15, 20 years where we're really starting to see some movement in these structures that are really trying to tackle these issues. And it really spans across fields as well, but it's exciting to see how psychology has, from the early 2000s started to involve itself in addressing these issues. So I want to jump a little bit forward now into thinking about, how we do this work and specifically in the realm of research. So this is sort of a simple framework that I use in thinking about what health disparities research tends to look like, and sort of how we can design our studies to answer several important questions. So first, I think about what disparities exist and for which populations. And so then we're really focused on the populations who are affected. And then related to that, sort of what are these social determinants that give rise to the disparities? Or in other words, what are these mechanisms? And then finally, how can we effectively address and eliminate disparities? And really that's in the prevention and intervention realm, what can we do to really make movement on these disparities that are really persistent to some of our best efforts to address them? And these questions really get to the hallmark of identifying, understanding, and addressing these disparities. And I would argue that counseling psychologists are really well positioned to address health disparities. And first and foremost, that's because of our field's strong commitment to prevention, multiculturalism, social justice, and liberation. So we come to this work with counseling psychology values and training that's focused on promoting equity. And then also because of our work at both macro and micro levels of society, counseling psychologists are, able to take on a number of different roles that allow us to, have in effect change at multiple levels, which I think is really amazing because not all public health professionals are able to work at such diverse different roles across these areas. So I've listed a couple examples here, and I'll come back to these later. But in thinking about the roles of a psychologist, how might you want to shape your career around tackling these questions? So we can train others in culturally and linguistically responsive care, design and adapt culturally responsive interventions and test their implementation, empower patient and community health, consult for organization level change in systems and in healthcare policies, advocate for equity-oriented policies. Of course, we can serve with individuals as counselors and psychotherapists for individuals who are affected by chronic health conditions, and serve as a researcher who investigates healthcare and health disparities. And really, in the face of these disparities, our goal is striving to achieve health equity. So how do we define health equity? So this, on the other hand, is this social justice-oriented goal that's focused on pursuing the highest possible standard of health and healthcare for all people. And the focus of health equity is really, attending especially to those at greatest risk for poor health and for people at the margins who often are underserved. And additionally, this really accounts for sociopolitical and socioeconomic influences on health and access to care, as I've been mentioning. And, it really kind of underscores this idea that individual health is community health, is public health, and working toward addressing these disparities moves us all closer to liberation. And again, this is a social justice issue. And I don't know if this will be surprising to folks or not, but the health of people living in the US has improved overall over the past 100 years, especially if you control for COVID and sort of the deaths that have been heightened during COVID. But so on the whole, health has improved, yet health disparities have persisted and even worsened despite medical innovations in treatment and a greater understanding of how social determinants influence health. Now we have this burgeoning and developing and progressing field of literature that establishes these disparities, and yet disparities have actually worsened. So why might that be? So we actually find that population health disparities tend to be created or even exacerbated with almost every major new advancement in health promotion, disease prevention, and treatment. And this might be surprising, but we can look at a few examples. And so one of my main areas of work is HIV prevention. So I'm going to share a couple examples from the area of HIV and then bring it home to mental health. So one area where we see massive exacerbating disparities is survival and death due to HIV and AIDS. So this is both about retention and care and outcomes. It's about when HIV and AIDS are diagnosed in an individual, when they receive care, and how well they're able to adhere to treatment, and then in mortality outcomes as well. Another example is uptake and adherence to HIV pre-exposure prophylaxis, which is a preventative drug that an individual can take prior to an exposure to HIV that will allow them to not contract HIV upon exposure. So HIV pre-exposure prophylaxis, or PrEP, differs massively by race and ethnicity in the United States in terms of what populations have started to take PrEP and benefit from its preventive potential. So we see large disparities here. And in terms of who can benefit from PrEP, those who might benefit but haven't been prescribed it and aren't taking it tend to be African American and Latino populations in the United States. We also saw this play out in the COVID pandemic with vaccines to prevent infection, severe illness, and death from COVID. So even at a point where the vaccines were free for individuals to take, uninsured people were half as likely to get the COVID vaccine. So we see these discrepancies even in the face of universal policies like allowing the vaccination to be free. And of course, we see this in mental health care access and utilization, where among low-income adults with a mental illness, white individuals are more likely to access and use services than individuals who are Black or Latinx and Hispanic. So this is really concerning that we're seeing these major disparities that persist and even get worse over time, even despite medical advances. So I also want to highlight a related and compounding issue about the difficulty of actually translating our evidence-based practices into routine practice. So studies have shown that on average, it takes about 17 years for an evidence-based practice to be incorporated into routine care. And only about half of evidence-based practices ever reach widespread clinical usage. And this is a problem because obviously the interventions and evidence-based practices that are either poorly implemented or not implemented at all can't possibly produce the expected health benefits that we're hoping they will. And even when an intervention is implemented, if it's not implemented effectively, or if the sort of like the effectiveness is lost during implementation, we are really missing a huge part of what our interventions are striving to do. So I want to highlight, I've basically talked about social and structural determinants of health, what they are, how they manifest, and some of the problems facing us in this area of work. And now I really want to move into the ways in which the roles we take on as psychologists can help us address these issues. So I've mentioned several different roles that psychologists can take on and why we're well positioned to address health disparities. So we can be researchers, therapists working directly with clients, faculty who teach undergraduate and graduate courses, staff trainers and consultants, public policy advisors, and patient advocates. And I want to dive deeply into each role here for a little bit, just to, give examples of ways in which we can attend to social and structural determinants through our work. And I would argue that will really increase the effectiveness of the work that we're doing. So in terms of research, research that attends to social and structural determinants is critical, but it can take a number of different forms. And that can mean, examining populations affected by health disparities and partnering with them in communities, delineating specific mechanisms that give rise to these disparities, and examining the implementation of interventions to alleviate disparities. And this work is really most effective when we are looking at multiple levels of analysis. So really beyond individual and psychosocial factors, incorporating interpersonal, environmental, societal, institutional, and structural factors. Another powerful methodological approach that I'd like to highlight is the use of implementation science, which helps us reach communities with effective, evidence-based interventions that are designed to be culturally responsive for them and attentive to unique needs of specific communities. And then finally, another area I'd like to highlight, a promising path, is the use of open science practices that disseminate our rigorous research on a wider scale than our typical sort of paywalled academic journals that aren't accessible to all. So this is really a way that we can engage communities beyond academic settings. So I've mentioned implementation science a little bit, and I'd like to provide a little bit more context. And so I've also talked a little bit about what gave rise to the field of implementation science. So firstly, it was that recognition that evidence-based practices take decades, over a decade to be implemented, and only about half of them ever reach widespread usage. And secondly, advances in care often contribute to or exacerbate disparities. So, knowing those two critical problems, implementation science sort of was created in attempts to address these issues. So it's the scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use by practitioners and policymakers. And its purpose is really trying to systematically close the gap between what we know and what we do. So this is often referred to as the know-do gap. And this is really, an approach that tries to promote uptake and effectiveness by addressing those barriers that can slow the uptake and effectiveness of interventions and enhancing the facilitators that allow these to be implemented. And I just want to say that the World Health Organization has actually recognized that bridging this know-do gap is one of the most important challenges for public health in this century and one of the greatest opportunities for us to strengthen our health systems. And, I think that really underscores that it's not enough to just establish the effectiveness of an intervention, because intervention uptake really depends on these contextual factors. So not just innovation and its effectiveness, but what kinds of barriers and facilitators are linked with its uptake. And implementation science can take many different forms. So I've already talked about the effectiveness side, where we're really trying to see what works, whether it works rather. But in implementation, we're really trying to look at how to best help people in places implement the intervention. So that can, sort of look at the effectiveness of implementing it too, including feasibility and acceptability for the users. And also facets of implementation research focus on implementation strategies, or kind of the actions and behaviors that can promote adoption of the intervention, and implementation outcomes. So really how much and how well it's implemented. Like, how is it reaching the individuals who we want to receive it? And this won't be a surprise to folks that we have plenty of science to practice gaps in psychology, or no-do gaps. And in fact, in 2020, there was a special issue on implementation science in the American Psychologist, and that issue provided really important areas for future efforts that would really greatly enhance the implementation of specific strategies and interventions to reduce and eliminate disparities. So I've named a few areas here that actually were based off of that special issue. But again, this is not really an exhaustive list, but just to get us thinking about what this research could look like. So disseminating information about evidence-based prevention and interventions for communities. So the example paper that focused on this was really attempting to increase parent awareness of adolescent treatment for substance use disorders. So thinking about how we can reach communities with information about the services that we can offer. Another focus could be improving the implementation of current treatment guidelines with practitioners. We've produced amazing guidelines for treatment, but whether and how well people are incorporating these is a big area that could be examined. Enhancing fidelity of treatment delivery across different settings. My favorite area to focus on is really the design of tailored interventions that take into account needs, preferences, capacities, and limitations of the people who will be using it or benefiting from it. And, lastly, really championing policy decisions that directly affect population mental health and focus on creating conditions for healthier lives. And, in the policy realm, this could also mean testing which policies are most effective at improving health, or even working directly with policymakers to increase their awareness of and support for different policy issues. I'd also just like to highlight how grant-funded research can be a major catalyst of this kind of work. So funded work does create opportunities for paid community advisory boards, paid staff who are trained and can gain professional development to enter the field. It can allow for the engagement of community members throughout the entire research process, from initial stages to the end and beyond as the cycle begins again. It can allow us to employ innovative community health worker and peer advocate models of care. And especially if there's opportunity for kind of sustained, continued partnership, there's really an opportunity for enhanced impact and building strong partnerships over time. In the realm of clinical practice, I actually think counseling psychologists are doing this work really well already, but I would like to highlight areas that are ongoing that I think are, important aspects for us to focus on in our work in training and education. And I'll talk more about this a little later too. So in the realm of clinical practice, psychologists should receive training in structural competencies. And really, this will allow us to take a person-centered approach, engage in culturally humble practices, and have an other-oriented stance when working with individuals and communities. This can also mean supporting clients to access services that address financial, safety, and social needs. I think that this work is often kind of considered to be the work of like social work, but this is an area where certainly if you're working in community mental health, I'm sure many of you are already doing this type of work with clients, really trying to address the many different areas of their lives that, are also affecting them that are outside of the therapy room. In terms of macro level efforts, so there are opportunities for us to engage in initiatives that focus on eliminating inequities, addressing discrimination, and reducing stigma. And through sort of development of tools that better capture multifactorial social and environmental stressors in clients' lives, We can engage in more comprehensive assessment. We can also sort of adopt approaches in our work, in these areas of assessment, treatment formulation, and report writing that really value self-determination and empowerment with clients. I want to talk a little bit about advocacy and sort of speaking as psychologists. So I don't think this is controversial at all to say that psychologists have professional knowledge that can and should be applied to social problems. And this is really being recognized at high levels of professional organizations, including APA, with the 2018 presidential initiative started by former President Jessica Henderson Daniel with the Citizen Psychologist Initiative. And APA Citizen Psychologist, that's really an award designated for individuals who are leaders in their various communities. They've engaged in this sort of prolonged activity level. They're contributing to lives of individuals in their communities through public service, volunteering, serving as a member on different boards, and other kinds of strategic roles that might not always be associated with like the day-to-day work of a psychologist in our careers. And, I know we have counseling psychologists who are citizen psychologists. So I think this is an area that we can really sharpen our skills and our training and work toward. And, I think this is important because, again, we have expertise that we can bring to address existing challenges to improve health and well-being locally, nationally, and globally. And I would be really remiss if we didn't talk a little bit about policy and what policy issues are relevant for psychologists. And again, not an exhaustive list. There are so many more, but I just wanted to highlight a few that are, very current. So PsyPact, prescription privileges for psychologists, comprehensive sex education, housing for the unstably housed, Medicaid expansion, mental health parity. And each of these issues presents a structural determinant that's both a maintaining factor and in many cases a fundamental cause of health disparities. And I actually want to highlight one policy in particular that we can consider in relation to social and structural determinants of health and how we can use our best supported approaches to addressing disparities. So I've talked about prescriptive authority for psychologists, which is really the opportunity for some psychologists who have advanced training in pharmacology to be able to prescribe psychotropic medications in the states where this is currently allowed. And right now, I believe it is just a few states like Louisiana, New Mexico, the Territory of Guam, Illinois, Iowa, Idaho, and also in the US military where this has been a more common practice. So these legislative efforts really came about because of the well-documented national shortage of psychiatrists that has really prevented people from accessing care. And, accordingly, sort of expanding prescriptive privileges for psychologists who have this advanced training really has the massive potential to increase access to care. So a paper by Chowdhury and Plemons examined the impact of this prescriptive privileges for psychologists legislation in states that activated it decades ago. So both Louisiana in 2002 and New Mexico in 2004. And the results of the analysis were that across the board, on average, there was a 5 to 7% reduction in suicide rates in the general population across these two states after the period in which the legislation took effect. So that's really huge. These numbers are huge, especially across entire state populations. But I want to note that this reduction was actually primarily driven by decreases in suicide for men, for white populations, and for the middle-aged population. So again, we're looking at a broad, universal public health policy, this structural determinant of health, if you will, and yet the gains were not equitable. So even with our best intentions at developing a universal public health policy, this isn't going to be enough. We have to do more. We have to be attending to these determinants in order to make sure that these gains are fully realized. So I want to talk a little bit about some of the my own work that I've been doing, both from afar now that I'm living in Minnesota and at the University of Minnesota, but also the work that I did on my postdoc over the last 2 years, serving on the New York City HIV planning group. So as an HIV prevention researcher engaged in this community work, I was a member, invited to be a member of the HPG, and I served on the Policy and External Relations Board. And our work through this board was really focused on assessing and addressing community needs, disseminating psychological science to key stakeholders on these issues of public health importance, setting up meetings with representatives to advocate on health equity-oriented policies, and targeting key areas for improvement, and building large coalitions of support within New York City and New York State. And I would like to, sort of again highlight how these determinants of health are connected. But, for some people, comprehensive sexual health education might, like at first consideration, seem like an area for a public health professional as opposed to a psychologist. Somebody who focuses on public health broadly and not somebody whose main work might focus on mental health specifically. But we actually provided a detailed but brief letter to our representatives that described how intimately comprehensive sexual health education is to mental health and well-being among adolescents and young adults. And so we shared empirical evidence about how receiving this kind of education is actually associated with improved knowledge of consent, better development of a healthy sense of self-esteem, violence prevention in romantic relationships among teens, a more inclusive environment for LGBTQ students where there were major reductions in bullying in the school environment and the schools where comprehensive sexual health education was implemented, and also, facilitating this sort of development of the relational and sexual communication skills that each individual needs in order to advocate for themselves and their needs in a relationship and make informed health decisions. So again, this is both an issue of public health that's intimately tied to mental health. And of course, our main focus was on, reducing the incidence of HIV and STIs among young adults in New York State. But again, this is very, very intimately tied to mental health as well. So now I want to highlight, we have a few minutes left of our time together, and I really want to highlight how education and training specifically can be leveraged to build sustainable partnerships with communities, promote community engagement, engage in culturally responsive practices, and address these disparities in communities. So I think in terms of education and training, advances in training and doctoral programs should be training psychologists in these structural competencies. So, psychologists emerge from their programs with an intimate understanding of power, privilege, and oppression, and how these forces shape determinants of health and well-being in our clients and in our communities. How to engage in community-based participatory research skills, which are really, a major set of skill set that, can't be undertaken overnight. This is something that individuals need training and experience in and mentorship in. And also cultural humility as this skills-based training area in our clinical work. And I would say that, I think we'll be most successful if we're able to build these areas into the structures of our programs and our institutions. And I think we should ask ourselves, if your institution doesn't incorporate community engagement into tenure and promotion processes, how might we be able to make that change? How might this work be valued? Because I think that if we create structures that value this kinds of work, it will be easier for us all to take on these kinds of tasks and engage in them. When they really dovetail nicely with a lot of the ongoing efforts, this is really another step further that would benefit the effectiveness of the work. And open science practices as well. How might you be able to, sort of surpass some of these barriers that make it hard for communities to access the evidence, the science that we're producing? Would it be possible for graduate training to include courses on social justice consultation, community-based participatory approaches, and open science practices, and really get hands-on application of skills in this area? I know doctoral students are already dealing with heavy course loads, a lot to pack into 5 and 6 and 7 years of training, but I think that this is critical for us to bridge some of these gaps. And, at the undergraduate and graduate level, what would it look like to build in capacities to give psychology away and sort of incorporate elements of sustainable community engagement into our work? And I've mentioned a few of these already, but I just want to highlight how, training will look different. It'll look in a number of different ways based on program and local needs. But these are a few ideas that I think, can be viewed as gaps in psychology. So, can programs build in bilingual and multilingual training and supervision into programs? Some programs have been able to adopt a scientist practitioner advocate training model, and I'd be really interested to, learn about outcomes from these programs and what kinds of, roles and tasks these trainees are able to go on to do as a result from getting that extra emphasis. I think it would be great if we could incorporate a legislative and policy lens and sort of, really make sure that graduates are prepared to, participate in this work if they would like to, developing policy statements based on evidence-based findings to engage in health advocacy. And I think we're doing the bottom two, well in most programs, but these are continued areas of emphasis that are really important. So infusing health equity into all aspects of training, so research and practical work, coursework, consultation experiences, and continuing to reach, recruit, and mentor students from underrepresented backgrounds to become psychologists. I do want to share in our last few minutes here an example of a hands-on training in consultation that I got to benefit from when I was a doctoral student in counseling psychology at University of Albany. So this was actually a publication that we wrote after having this training experience in our course, which was led by Dr. Mickey Friedlander. And, we really in this article describe a team-based assignment for enhancing multicultural competencies. So the students in our class, we were all tasked with working over the course of a semester and opportunities for contributions beyond the semester as well, working with a community organization, agency, or institution to kind of improve service delivery or tackle an issue that was identified by the population. And this work took place often in collaboration with underserved populations in the Albany, New York community. And some of our completed projects were creating an online educational resource for on the topic of trauma and resilience for displaced Syrian medical students, delivering a socio-emotional parenting workshop to parents who were served by a grassroots organization, training medical residents on microaggressions in healthcare, and presenting a workshop on a culture of stress for Muslim leaders in local mosques. So I think, these projects really required teams to integrate theory and research and work on this sort of collaboratively identified problem, engage in consultation with an agency and its professionals, and practice self-reflection as well. And these projects really required us to focus on trust, collaboration, skill building, empowerment, and social action. Develop a comprehensive assessment that also included dissemination to sort of translate these findings back with the community. And it really emphasized, where possible, creating sort of long-term partnerships and a strong value for this sort of concrete contribution that would fill a distinct need that the organization identified. So I just have a few points left that I'd like to make about community engagement. So a lot has been written about effective approaches to this work. I'd like to highlight one model by Plested et al. That really focuses on community readiness for community change and sort of how we can take these participatory, widely applicable models and apply them to a variety of health issues. And so, at the outset, that really means assessing stage of readiness. That also means sort of looking at what existing community efforts have been undertaken, what are community knowledge of those efforts that have been existing, what kind of community leadership and climate is there to take on this work, what kind of resources are there, and then through this process, really kind of working together to guide development of an intervention or a program that's relevant and appropriate and suited to the population. And then, participating together throughout the process up until the application of results. And really the, kinds of outcomes we're focused on here are community empowerment through engagement. And, this leads to professional development and training as well. So it's really like this kind of approach is really built upon those ideals of person-centered care, the belief that individuals' views and inputs and experiences can help improve overall health outcomes when applied to these problems, empowering people to sort of take an active role in improving the health of their community, and, emphasizing self-determination in this sort of nuanced way of approaching these issues. I worked on a book chapter in an open educational resource through Division 17 a couple years ago with Meredith Maroney and Sharon Horn, where we outlined sort of principles of community-based participatory research and ways in which this, is really strongly associated with the work of counseling psychologists and could be implemented into programs. And I just wanted to highlight kind of these 9 principles that if we incorporate into our community-based work, we're sort of poised to really enhance the effectiveness and also, increase the chance of success of these partnerships with communities. So recognizing community as a unit of identity and building on the strengths and resources of the community, facilitating collaborative and equitable partnerships, and really aiming to ensure that this is throughout all phases of the research process. Making sure that this work provides mutual benefit, reciprocal transfer of knowledge and skill, and focuses on problems that are deemed to be relevant for the community. And then, really disseminates and shares back findings in this collaborative way. And this is really, an attempt at driving this long-term process with sustainability, which especially can be hard for trainees who are taking on this research. And it also underscores the, immense need for training and for skill in this area. And this work can lead to a number of different outcomes. These are areas that can really move the dial to address disparities. I won't read all of them, but, suffice it to say that, these are areas for action and action-oriented work. And I just want to have a few key takeaways of the talk today. So really, health disparities do not have to be inevitable. We can pursue interdisciplinary approaches to address disparities in our work that centers the needs and priorities of underserved communities and populations at the margins, focus on policy and implementation, which are 2 areas that are often neglected, foster engagement using participatory strategies in these ongoing and bi-directional partnerships, disseminate the findings back to communities, and promote education and training that diversifies the psychology workforce. Again, I mentioned our roles of a psychologist. These are sort of areas that I focused on throughout the talk, but kind of one slide that summarizes across the many roles, areas of work that we could be focused on that addresses social and structural determinants. And now I want to make sure we have time for Q&A. And I know there are comments in the chat as well as the Q&A. Thank you all.
Thank you, Dr. Ertl. Would it be helpful maybe if I read the Q questions aloud for you?
Sure. Why don't you do that?
So we have one in here. It says, I'm wondering your thoughts, Dr. Ertl, on how historical events, I'm thinking Tuskegee, impact what you're talking about regarding underutilization of some health services by communities of color. Dr. Irving.
Yeah, this is an excellent question. And I think, this is so tied to sort of those social and historical influences, including medical racism that has driven medical mistrust in communities. And, I think this is being recognized by entities like the NIH and is sort of this driver behind why partnering with communities in the work is essential to sort of have that power sharing and that ability to collaborate together on issues of relevance. But absolutely, I think this is an excellent point. And especially in the realm of HIV prevention and treatment, some of the reason that ART or antiretroviral treatment and HIV PrEP are underutilized is really deeply connected to medical mistrust. And, recent studies in the last 5 and 10 years have discovered this as well. And I think it's also true for mental health care too. So thank you for bringing up that point. Absolutely.
A lot of kudos here in the chat.
I'm just checking the
Dr.
chat
Erdl, yeah.
now.
And if folks have questions, feel free to drop at least one more in. We do have a little bit of time. We'll just give it a minute.
And I will share the slides, definitely. Yep. Oh, you shared that. Good. Great. Oh, a shout out to you, Albany. I love that. Go Great Danes.
I actually do have one too, Dr. Erdl, if you don't mind.
Yeah.
I love the discussion about the consultation projects. I'm wondering if you could just mention a little bit about the reflexive process in there
Mhm.
that maybe was embedded into the project. Like, what did it look like for students or for you or for whoever was involved, and
Yeah.
what are some best practices there?
Definitely. And I'll say that, oh gosh, we probably conducted the projects in, it must have been 2018. So it's been a few years now, but essentially, and this was actually a course that focused on, psychotherapy process and outcome too. It was sort of integrated into a class that's already a requirement of counseling psychology doctoral programs. In this work, we were focused on partnering with a community, and the partnership actually took place even before the semester started. We started to plan which organizations we would kind of approach and consider working with in Albany. And our professor, Dr. Mickey Friedlander, had connections to these organizations, and these were people who were really excited to, be able to have sort of this opportunity to work with a doctoral trainee with, this experience and training in mental health, who was eager to work with these organizations. And it was woven into the course where we had like ongoing meetings, at some points of the semester, even on a weekly basis with leaders of the organization we were working with. Myself and my student colleague, we worked with the grassroots organization that supports parents in one specific kind of underserved neighborhood in Albany. And through meeting with the leader of the organization and also sort of the parents who were participating in their services, we came to realize that a lot of them sort of were being, in this role as a parent, but not having a lot of training and education and kind of the socio-emotional elements of parenting that were really leading to burnout. And that was sort of a technical term we use, but from what they shared with us, they were really describing the burnout of sort of anxiety and depression, and how mental health can really affect the way that they were feeling like they were able to parent. Um, and working with our instructor, we had regular check-ins throughout the course. This was a course that met once per week. So we would check in at the beginning of class about our projects and how they were progressing. We would have like one-on-one meetings with our instructor in terms of the plan for what we in the organization kind of came to, in a sense of what kind of product we were working toward and creating together. And then throughout the semester, we actually had to write, I think it was like a 15-page paper that incorporated theory, empirical sources, sort of the evidence base for why we were focused on the topic that we were, and why we thought the product we were creating with them would be helpful. And then at the end, the end of the paper really was this sort of self-reflective aspect of what it was like for us to engage in this consultation in a community. And I think, as a trainee, as like a second or third year student, it was this really exciting opportunity to be, involved using my, burgeoning skills as a counseling psychologist and training to work with a community where people's lives, they were coming to this organization for services, asking for something that the organization didn't currently offer that we could help provide with them. So it was really empowering for me as a student as well. So we focused on that self-reflective piece as well about, how did that change, our view of what counseling psychologists can do in communities. And I do hear from students that they don't get a lot of opportunities for consultation. And those experiences, I think, can be really helpful and eye-opening.
Wonderful. Well, thank you again for taking time and energy to be with us today. Our gratitude to you, Dr. Erdl, for presenting. And I see a lot of, again, appreciation as well in the
Thank
chat.
you.
A gentle reminder to participants who attended the full webinar to earn continuing education credit. You will get a follow-up email within 3 business weeks of the webinar, and that webinar will include, or that email, I'll get there, will include a link you can click on to complete the evaluation form and request your CE certificate of attendance. So thanks again for joining us today, and wishing everyone well on the Thursday.
Wow. Thank you.